Good afternoon, everyone, and welcome to Workflow Optimization, the next frontier in healthcare. This is a virtual event organized by BPM Health with sessions and demos that members of BPM had put together for the HIMSS conference this week, which unfortunately was canceled. So we lined up 2 days just to share them more broadly with the healthcare community. So my name is Tracy Berardi. I'm Program Manager of BPM Health. This is our final session of the 2-day virtual event. And before we get started, just a little background. BPM Health is it's a new community of practice, fairly new. We launched this community in September of 2019 under the Object Management Group, or OMG for short, which is a standards organization located just outside of Boston, Massachusetts. We're really excited about BPM Health. Our real initiative is to improve the quality and consistency of healthcare delivery. Specifically, our focus is on using open IT standards, BPM meaning business process management. So we're leveraging business process and case modeling standards to model clinical pathways, clinical guidelines, and other healthcare knowledge to make this knowledge computer consumable to be shared across health institutions, to follow the patient, and ultimately at the end of the day, used to help doctors make decisions and improve outcomes. And help patients. So really thankful for all of our founding members, which are the logos you see on the bottom of the slide that helped launch BPM Health. And we now have 5 working groups, 5 sub-communities where the magic happens, the work is being done. So there's authoring, adoption, implementer, methodology, academic and professional education. Our speaker today, Jane Shellum, she's co-chair of the adoption working group. I'm sure she'll touch base on that quite a bit in our talk. And I just call this out because all the sessions that we've brought together, the content, these initiatives map back to work that's being done in these groups. And part of why we're holding these sessions is to invite you, those on the line, if you're interested in getting involved, there's a path to do so. You can visit our website. It's bpm-plus.org, and you can join as a member through your organization or individually as a participant. But without further ado, let me transition now to today's session using Semantic DMN to represent the logic for cognitive support tools with Jane Shellum. Just a quick note, we love your questions. You can enter them in the questions tab and we'll address those. There's also a link in the chat box to where we're posting the presentations and the slides for reference on demand. Jane, why don't I give you the floor? Thanks so much for joining us this afternoon.
Thank you very much for having me. And thank you all for your patience. I know it's disappointing not to be able to be at the live sessions, and really appreciate the participation in these video sessions. So as Tracy said, I'm going to be talking about how we've been using Semantic DMN, so DMN with clinical meaning, to represent logic in our cognitive support tools. And so before I get into the how we're using the BPM family of languages, I wanted to talk a little bit about the why. And really the reason behind it is that we have a business strategy, an organizational strategy that is centered around clinical knowledge. And we're fond of saying that knowledge is our most scalable asset. But in fact, I get a little nervous whenever people say that, because it really should be our most scalable asset. But the fact of the matter is that knowledge that's buried in code rather than surfaced in manageable artifacts that are based directly on a clinical vocabulary and domain models is technical debt, and in the long run, it's really unsustainable. But at the same time, knowledge that's represented as human-only readable artifacts isn't routinely actionable, and that's difficult to scale. And so we really need another solution. And as we were thinking about how we manage knowledge at the Mayo Clinic, there were 4 imperatives that we identified. The first is that we really need to be able to facilitate knowledge curation. It's really important that clinical knowledge curation is a core part of what we do at the Mayo Clinic, and we need improved tooling, and we need improved knowledge representation and methodology support. The second imperative is to really know what we know, meaning that we need to be able to have a system, which we call our knowledge content management system, that manages the knowledge life cycle and allows the delivery of that knowledge in multiple formats. And so we need the ability to have metadata and relationships between pieces of knowledge and all of those things that facilitate that knowledge life cycle. We need to be able to deliver the knowledge. So we facilitated knowledge curation, we're managing it well, but the bottom line is we have to get it to the point of care. So we need to provide searchable, contextualized, clinician-consumable knowledge through APIs to multiple applications and multiple business partners. And we need to be able to measure its use and its impact and cycle that back through. So we have to be able to deliver. But in order to deliver the knowledge, we actually have to have knowledge-enriched data, because the way that we deliver knowledge to the point of care is by having a robust data, patient data pipeline that standardizes, normalizes, and enriches and contextualizes clinical data so that we know which knowledge has to be brought to which point of care. So those were the 4 imperatives that we identified. So BPM Plus actually helps us address each of those imperatives. It helps to facilitate knowledge curation because it provides a way to faithfully represent clinical knowledge that is both human and readable. So we like to say you go straight from SME to screen. So I can work with a BPM Plus model with a clinical expert and talk through the clinical knowledge and represent it in a way that can be validated by the SME, but at the same time can be processed computationally. It also helps us to know what we know, meaning that BPM is not just it's not just Visio. It has semantics behind it. It has meaning. It has standard metadata that's based on controlled vocabularies, and it provides transparency into our knowledge assets in a way that just blobs of text can't do. It really helps us to deliver curated knowledge because we can develop a single model-driven technical solution that delivers knowledge across specialties and care settings. So we can have a technical solution that doesn't have any embedded clinical knowledge. It consumes these models, which allows us to scale. We can do something for pulmonary one day and for GI the next without developing new systems. And then conversely, a single BPM Plus model can be applied in many different ways. So it gives us a lot of flexibility with respect to delivery. And finally, it helps us to deliver knowledge-enriched data by helping to very succinctly define input data. It's a way that we can define and label the data enrichments that are needed. So our clinicians tell us what data we need from the medical record or what data we need to generate based on primitive data from the medical record. And that's part of the modeling process. So that was a little bit about why we're using the BPM Plus language. And so I'll talk about how we're applying it. Now, we are very focused on DMN. And for those of you who have been listening over the last 2 days, I'm sure you're familiar that BPM Plus is a family of languages, and case management model and notation and business process model and notation are very focused on the orchestration of tasks. where decision model and notation is just that. It's about formalizing decisions that need to be made. What are the inputs and what logic is used to generate an output? And so while we use the family of BPM Plus, our work has focused in large part on the use of decision model and notation. And we use it to define data enrichment logic, to define scoring tool logic, to define the logic for making recommendations for clinical decision support, and finally to support human decision-making models for advanced cognitive support. So I'll go through each of these use cases in a little bit more detail. So the first one is data enrichment logic. And so just as an example here, a scoring tool called the Hasblood score asks for abnormal renal function. Well, you can't go to the medical record and find in a flow sheet a yes-no answer to whether a patient has abnormal renal function. But what you can do, and the way that it's defined in the scoring tool, is determine whether or not a patient is on dialysis, determine whether or not a patient has had a kidney transplant in the past, and look at the value of their most recent creatinine to make a determination of whether or not the patient has abnormal renal function. And down in the corner here, you can see the decision logic that would be used to identify, based on that primitive data, the answer to the question, does a patient have abnormal renal function? The second way that we use it is for scoring tool logic. And so here we have a CHADS2-VASC score, which is a score that measures your likelihood of having a stroke. And again, we can formalize all of the inputs, whether it's primitive data or data enrichments, and you can see the logic that is used. It's simple scorecard logic that adds up the points for each of these characteristics. What's really nice about using DMN for this is that it's very easy for a SME to check the logic and say, yep, you got this right. And at the same time, this is computable so that you don't have to translate this into code, where there can sometimes be miscommunications between the spec and the coding. This one is a little scary looking. It really is not as bad as it looks. This is using DMN to make patient care recommendations. So this is traditional CDS. This looks better on a big screen. I'm sorry, it's probably illegible if you're watching on a small screen, but the square in the lower right-hand corner is the ideal management for hyperlipidemia patients. What characteristics should be used to determine what type of statin therapy the patient should be on. And so this is the ideal state. So based on these characteristics, should a patient be on high-intensity statin, moderate-intensity statin, a statin escalation, non-statin escalation drug, et cetera. So that's the ideal. Then what we do is, in the other box, we have actual. So we're looking at what is this patient's LDL, what drug and what dose is the patient currently on. And we can look at that data and compare ideal to actual. And by combining those two things, we can make a recommendation. So a patient, the ideal therapy for a patient might be that they're on high-intensity statin, but we know that they have a treatment goal. And if they don't make the treatment goal, then we want to escalate to ezetimibe. So that's where we look at the ideal treatment plan. We look at where the patient is, and from that we can generate recommendations. So this is just a snippet. There are quite a few more rows to this, but this is what that logic looks like for the recommendations. So if a patient is over 75, has ASCVD, and they're very high risk for future events, then they really need to be on a high intensity statin with an LDL goal of 70, but because they're over 75, there's no escalation. So then the last example is the one that I'm going to dig into a little bit more, because it's non-traditional decision support. It's more cognitive support, and we call it advanced cognitive support. And what we're trying to do is enable better decision-making by combining a synthesis of the patient record with the codified clinical knowledge that's in the BPM Plus models. And what we really want to do is to apply what we know about medicine, which is the knowledge, to what we know about the patient, which is the data. We're bringing together those two worlds. And we're doing it in a way that reflects how physicians think about a case. So how this works is that it's a Smart on Fire application that's driven by BPM Plus models, which are stored in a knowledge repository. And those models interpret information from both patient data and from knowledge resources. And all of this is tied together by a variety of services, technical services, both at a platform level. So we have a knowledge management platform, which is the technical infrastructure that allows us to manage complex knowledge, like what's in the BPM Plus models, as well as patient data. And then the application services, which drive the UI and what we call the gateway, which is what brings the knowledge and the data together. We use the models to power this application in a lot of different ways. The models provide us the information needed to manage the navigation, to tell us how to display patient data, to tell us how to display knowledge content, human readable content, and to control what actions are available to the user. So this is an example of using CMMN, case management model and notation, to represent a care process model. And we put cognitive in parentheses here because very often you will see clinical pathways or care process models that are very focused on process. So the flow of the patient through the care setting. The focus here is more on the cognitive process or the decisions that the clinician needs to make. So in the case of atrial fibrillation, the big decisions for managing a patient are treating the contributing factors, treating the arrhythmia itself, which can be broken down into a choice between tackling the rate or tackling the rhythm, and preventing a stroke. Those are the big cognitive tasks. In addition, we have a cognitive task, which is to review the current status or to orient yourself to the case. So these don't have to occur in any particular order, which is why we use CMMN. If it were a deterministic process, we would use BPM instead. If you had to treat the contributing factors before, you could treat the AFib before you could think about stroke prevention. So the way that decision tasks, affect the navigation. Here's an example. You see a task in the CMMN model goes to a control on the screen, treat contributing factors. So on the screen, each of the tasks from the model becomes a button or a control for navigation on the screen. We also use the decision models for data grouping. So we can bring back a ton of data from the patient record, but showing how the data fits together, those decisions from DMN drive the user interface and the application behavior. And so we actually, in the DMN, annotate the decisions. So as I said, these are semantic languages and they carry all of the information needed to manage the process and manage the active decision making, but we add additional annotations to those decisions. These different types of decisions are not important, but the idea is that the type of decision, based on the way that it's annotated, addresses the purpose of the decision. Is it to assess the patient or to decide what I'm going to do next? So a decision can be actionable or an assessment decision. We look at how the decision is made. Is this one we expect the computer to do, like the scorecard? Or is it naturalistic, that we don't even try to capture the logic? We're using the decision to assemble the inputs and present it to the clinician. We control whether or not to display a decision. so the decision might be very important for knowledge representation, but it doesn't need to appear on the screen. The type of answer in the decision, so is this something where I'm choosing from among 2 or 3 different choices or not? And again, how the inputs are displayed, they can be aggregated, they can be in a timeline view, there can be a central input around which the others are arranged. And finally, we look at who the decision maker is. So if it's a shared patient-clinician decision, we can annotate the decision to indicate that. So again, these are a little bit hard to see on a smaller screen. I hope you all are looking at a bigger screen than I am. The decision types, this is just an example. When I mentioned an aggregating decision, this is current cardiac status, and the purpose is just to bring together all of the inputs to that decision. The clinician is assessing what this patient's cardiac status is, but we're providing all of the information they need to make that decision. A shared decision actually brings up a decision aid, so we can provide a link out to decision aids. A choice decision is I can choose from among actions that I could take for this patient. I could order any one of these medications. And a temporal correlating decision is just a timeline type of decision. How do these inputs relate one to another over the course of time? So again, each of these comes from a decision model, but the annotations on the decision model that tell the application what type of decision it is drive the UI. We do have, we use the knowledge sources in the model. And this is part of the DMN spec, is that there's an authority or knowledge source. We're actually using content from our in-house knowledge base that we have for clinicians known as Ask Mayo Expert. We can actually deliver the human readable piece of content that goes with the decision. So the decision here is how am I going to treat atrial fibrillation? We actually have a human readable piece of content that gives advice on how you think about rate control versus rhythm control, but we can also bring back all of the data that you need to make that decision. And so again, the decision inputs in the model map to the patient data that needs to be pulled from the record. And this is really the key piece right here, is what we're doing is in the modeling with a subject matter expert, they're telling us what's important, and we can use those inputs to query the record and pull back the relevant data. So the way that we do this, excuse me, the way that we add clinical semantics is that each of the decision inputs in those models is annotated with a clinical concept. So for example, most recent LDL, most recent low density lipoprotein, is an annotation. That concept is an annotation on the input that goes into the model. And that concept has an operational definition. So we have an ontology, a clinical ontology that includes the concept most recent LDL, and that concept has an operational definition. And an operational definition is, how do I know? And each concept has a data type definition, which is, what does it look like? So in this example, we have the concept of on anticoagulants. That's an input to a decision that we have. And the concept of on anticoagulants has the operational definition, which is a FIRE query that looks at a value set of all the codes for all of the anticoagulants we're interested in. And it has a data definition that tells the application this input is going to come back in the shape of a FIRE medication statement. So just by annotating those inputs with a concept, we can get all of this information that the application needs. This is what our clinical ontology looks like. So again, it just is just that, it's clinical situations, and each of these has a unique identifier that we can then put into the model so that we can connect the data, we can connect the decision input to the data definition and the operational definition. We have an editor that we use to create the operational definitions, which are FIRE service profiles. So we have an editor that contains all of our concepts, and our knowledge engineers can go in and write the structured query. So that's how we get the clinical semantics into the model, and it's really that piece of it that binds this clinical knowledge that's modeled in BPM Plus to actual patient records. So the benefits of BPM that we've realized so far is, as I mentioned before, the visibility of the knowledge. It's a mature standard. There are multiple vended tools out there. It's a visual language that is understandable by SMEs, by subject matter experts. As I mentioned, there are these editing and execution tools that are out there because this is a mature OMG standard that's been used for many years by many businesses. It facilitates the shareability of knowledge with our partners, with our customers, and internally to our organization. We have the flexibility to model to meet different business needs. These models can be used as the basis for all types of different things other than what I've shown you. And finally, and most importantly, is you all. There's a community of practice out there of people who are working hard to figure out the best way that we can make computable clinical guidelines, computable pathways. There's a very active community of practice with the exchange of ideas and best practices, and that's been a huge help. Okay, questions?
Great. Thanks, Jane. Yeah, now's a
Should I
great
give
time.
you back? Okay.
Oh, sure.
Sorry.
If you want. Actually, I have the BPM Plus website up here.
Okay.
Which is always a fun reference point. And we're just waiting. It doesn't look like any questions have come in at this time, but if you have one, feel free. And while I have everyone's attention, I'll just point you to this is our website, bpm-plus.org, that I had mentioned. Up on our events tab is where you'll find, this is the event from today. And this is where we are cataloging the sessions that we've had yesterday and today. So if you're looking for some more good content, there's slides and videos, and we'll have the sessions from today up by tomorrow morning, I would say. So yeah, actually, Jane, it looks like no questions. Very thorough. Oh, no, just kidding. As soon as I say that, here's one. I'll go ahead and read. Jane, thank you so much for the amazing presentation and your work. I believe you are so far ahead in leading the way to better healthcare and research outcomes. What advice do you have for others? How do we begin to catch up? Isn't that nice?
Oh, well, first of all, thank you. And, I don't know how much farther ahead we are. There are so many good groups that are tackling this. I would say joining the community of practice, join some of the OMG phone calls, work with other groups to see what they're doing. Take a stab at trying to model out something in your organization and get a feel for how these tools might work for you. I guess would be my advice. What I showed today, we didn't do overnight by any means. We're on year 3 now of that advanced cognitive support application. But I do think the biggest hurdle when we were starting out was finding a way to represent knowledge for a knowledge-driven solution, and BPM Plus has really filled that role. And so now most of our effort is going to that piece of connecting with the medical record. But I would say get engaged in the community and exchange ideas with others and try it out.
And then another compliment, not a question, but very interesting presentation and use of DMN, smiley face.
Oh, thank you. Thank you, whoever that was.
And this is a good follow-on. Where do you see Mayo being with this in a few years?
It is my hope that this is a tool that will be used in the exam room by our doctors, and we will be releasing before the end of this year the first version of this. It is complementary to our EHR, so the workflow is that if there is one of these care process models available for a patient, there's an indication in the EHR for that patient, and the clinician can launch it from there. And so, yet by the end of this year, we hope to have an initial implementation. And in a few years, we hope to make this an integral part of our practice and a tool that our practice leadership can use to make sure that we're getting the practice consensus out to our geographically dispersed group of clinicians. Yeah, that's my fondest hope. That's what I do with my time, is to try to get this done by the end of the year.
Excellent. Great. Well, that wraps up our great webcast, and it's been a great 2 days of sessions and demos. Thanks, Jane, for capping this off. Great presentation. And thanks for everyone that stuck with us and joined us this afternoon. It was very good to have you. We hope to see you on a future webinar. And if you're interested in getting more intimately involved in some of the working group activities, we are planning a virtual working meeting in the next couple of weeks. What was to be a face-to-face in the Washington, D.C. area, we're now going virtual. So to participate, you can feel free to email me, actually, if you want to reply to your webinar confirmation, or go to our website, join BPM Plus Health. So once you sign up for the working groups, you'll be alerted over email, and now's a good time to join. So with that, have a great rest of the day, and we'll see you again soon. Thanks.